Hello, and welcome to the GRACE podcast series. My name is Denise Brock, and I am the Operations Director for the Global Resource for Advancing Cancer Education, or GRACE. In this podcast series, we interview patients, advocates, and healthcare professionals to provide the most updated information for our community and to highlight important issues facing those dealing with a cancer diagnosis. We hope you find this information valuable. For questions or comments, please visit us at cancergrace.org.
Welcome to this segment on HPV negative incurable cancer. I want to just start by defining terms. Head and neck cancer, it's pretty rare for it to present as an incurable disease. So for example, the other cancer I treat is lung cancer. 3/4 of lung cancer presents unfortunately spread to multiple sites. And so the patient who starts off as incurable hasn't seen any chemo or other drugs before. I think it's important to start with head and neck cancer to recognize that when it becomes incurable, it's usually after a failed or multiple failed attempts at cure. And it's also important to define terms a little bit because they get confusing here. Stage 4 cancer and head and neck cancer is not necessarily incurable. There is such a thing as curable stage 4 cancer. And the flavors of recurrence are heterogeneous. We can have recurrence only at the site of disease that nonetheless is no longer curable. We can have recurrence only distantly, and we can have recurrence that's both. And regardless, this incurable state we call recurrent/metastatic. So let's start with standard of care. Dr. Sheth, right now in your clinic, what are you thinking about if you see a patient sent to you with a designation of recurrent metastatic disease? What are you thinking about to decide what to talk to that patient about for their options?
Yeah, so thanks, Dr. Weiss. I look at a few factors. Number one, as you mentioned, I look at their HPV status just to think about their disease biology. Number two, and this is very much based off of the Keynote-048 trial that was published now almost 5 years ago. We're getting old, but which really changed the landscape.
You still have hair.
Yeah, which changed the landscape for how we treat head and neck cancers in the recurrent metastatic setting with the addition of immunotherapy. And so the first question I ask about that is, do our patients' tumors express something called CPS or a combined positive score for PD-L1 expression? And so without getting into the weeds, we can see PD-L1 expression on immune and tumor cells. And so essentially CPS is a fancy score that gets kicked out and calculated a score from 0 to 100. So if you have a score that's positive, so at least 1 or higher, then the way the FDA label works is that you can give immunotherapy, so pembrolizumab or Keytruda by itself. If it's a score of 0, then you have to combine it with chemotherapy. Now, this is, again, an intense area of debate of how to best treat patients based on that CPS score, but I tend to give patients who have a higher score, 20 or greater. That's where I consider doing immunotherapy on its own. If it's 1 to 19, I'm typically adding chemotherapy. There's, of course, nuance to that, but that's my general practice for how I decide how to treat patients in the first-line recurrent metastatic setting.
Absolutely. Dr. Patel, anything to add to that from your practice?
No, I'd say, in terms of stratifying patients, using that PD-L1 score is very helpful. And then, also thinking generally about the patient and where their disease is, their burden of disease, how symptomatic they are from their disease. When you're thinking about doing a single agent treatment, such as pembrolizumab, or doing a combination with chemotherapy, thinking a little bit also about how long from their prior treatment, since as Dr. Weiss mentioned, these are patients that have had some kind of prior treatment for their head and neck cancer, how long it's been since their prior chemotherapy can be helpful in judging, the success of single agents or combinations.
The only other thing that I would add from my practice is that the first question I ask for an incurable patient is, are they really incurable? Thinking back, gosh, you want to talk about being old? Thinking back to the first phase 1 patients of pembrolizumab, or when it was MK3475, some of the first few patients that were sent to our center for this trial were actually curable. There was something available to them that hadn't been spoken about, and they didn't go on to get that trial, but instead, at least in 2 cases I can think of offhand, went on to get a salvage surgery that cured them. There's a lot of nuance here that maybe we don't want to go into in this context, but reirradiation can be an option for some patients. Salvage surgeries can be an option for some patients. To summarize, maybe over summarize, these are more brutal than when you do them in the first place. And so there needs to be good counseling from a good radiation oncologist and a good surgeon so that a person can plug their values into that and say, is this what I want or is it not? And if the answer is it's not or it's not possible, that's usually, I think, where they come back to see us to talk about what options we can offer, with the goal, unfortunately, no longer of cure, but of preservation of quality of life and improvement in duration of life. So right now, in standard of care practice, we've spoken about the options of pembrolizumab or Keytruda alone, or with chemotherapy. Anything new on the horizon? New data to talk about?
Sure, I can start. I think the most
We
buzzworthy
knew we were going to make you go there.
the most buzzworthy data that was presented at the Arizona conference in February was the results of the LEAP-10 trial. So the agent that was studied is an oral chemotherapy called lenvatinib or Lenvima. And its mechanism of action, it's it's a tyrosine kinase inhibitor, or TKI. And its mechanism of action, it targets many different pathways, but the main one is to really shut off the blood vessel supply for the tumor. And the thought is that if you can shut that off, then you can help decrease the growth of the tumor. And so what this study did was it was a phase 3 trial. It's evaluated patients who got Lenvima with pembrolizumab or pembrolizumab monotherapy. All patients had to have a positive PD-L1 expression. And so, I think there was a ton of enthusiasm about this agent just because the phase 2 data looked very promising based on response rates. So a fever pitch in the room, what we knew was a negative trial, but, we finally got to see this data in Arizona. And I think what was so, I think maybe shocking about it is that when you looked at the breakdown of the response, Lenvima plus Keytruda or pembrolizumab actually doubled the response rate compared to pembrolizumab alone. When you looked at the median progression-free survival, so how long patients could stay on without their disease progressing, that also almost doubled. But I think what was really surprising was that the most important and the primary endpoint of this trial was overall survival. And, unfortunately, it showed that the combination with Lenvima, Pembro, had even a little bit a smaller or less overall survival of 15 months versus 18 months versus pembrolizumab alone. Not statistically significant, but again, just very divergent of where we thought the data would go. And so, I think this is a lot of speculation of why the data was negative. I will just add quickly, I think the downside to Lenvima, even though I'm a fan of it, is that it's quite toxic, and so it works, but patients have problems with low energy state, high blood pressure, nausea, vomiting, diarrhea. And so, if you're starting off at a high dose, patients don't do well on it. And I think what we haven't seen all the data, what we may see is that patients who got this therapy were probably treated and just didn't tolerate it well enough where they weren't able to receive more subsequent therapy. And that's probably why their overall survival was inferior, not superior, at least to the pembrolizumab monotherapy arm. Stop there.
Dr. Patel, I made you give the bad news last time. So where's our hope in HPV negative cancer?
Yeah. So there are a couple of agents that we've seen with single arm data, so in earlier phase studies that are targeting the EGFR pathway, so the epidermal growth factor receptor, which we've learned, we've known for a long time is an important growth factor in head and neck cancers, and we have some therapies that are already approved to target it, namely cetuximab, which is an EGFR antibody, which by itself has relatively low response rates and duration of response, but is an option for patients. So these two newer agents that we've seen in studies are basically modifying EGFR in different ways to see if we can enhance that response. And what we've really seen is that the activity has been quite encouraging, both alone as single agents, but then also there are ongoing studies that are combining it with immune checkpoint antibodies. And so one of these agents, petosetamab, is an EGFR LGR bispecific. So it's targeting two different proteins and has been shown to have increased activity in terms of decreasing the level of EGFR, showing encouraging response rates as a single agent, but then is also being looked at in combination with pembrolizumab. And then the second agent called BCA-101 is an EGFR and TGF-beta bispecific targeting. So it targets this protein TGF-beta, which has a number of different roles in cancers, but one of them may be to decrease the activity of the immune response. And so by combining these two pathways, the hope is that one, we get the anti-EGFR activity, but that maybe you're actually getting some immune activation. And so that's also being looked at in combination with immune checkpoint antibodies in larger randomized studies now, so we can really see if these have better activity. So those are encouraging agents on the horizon, hopefully we have for our HPV negative patients.
Thank you. And I think I'd point out that these agents have more convincing activity in the HPV negative. This is not just hope, but hope specifically for the HPV negatives. Historically, we've known that EGFR, the target of these drugs, tends to be more overexpressed, tends to be more of it in HPV negative cells. Our clinical data for efficacy of the existing agent, which happens to be called cetuximab, is better in the HPV negative patient. And so it makes sense that that's where these are being developed, and I'm really excited to see what happens with them. I think it might be our first advance in quite a while. And what's nice is that it's an advance that is not chemo. While they're not side effect free, you can have plenty of rash, some infusion reactions, a little bit of diarrhea. I think it's fair in parallel to acknowledging these problems to also have the happy hope that they are less toxic than chemo. Well, thank you for joining us for this segment on HPV negative recurrent metastatic disease.
Thank you again for joining us. This podcast was made possible by the generosity of our sponsors and you, our community. Please like and follow us on YouTube, Facebook, Twitter, LinkedIn, and Instagram. Send us feedback, share your story, donate, and visit us for more information at cancergrace.org. Thank you for listening.